and when it can be chosen. As far as the concern of vaginal birth to be chosen is taken, it is that when a patient is beyond 37 weeks gestation, because you know that we take 37 weeks gestation as term pregnancy. So when the patient is beyond 37 weeks gestation, then she can go for vaginal birth after cesarean depending upon indication. And also we have to counsel the patient that before proceeding towards vaginal birth after cesarean, we have to rule out the contraindications relating to the vaginal birth after cesarean. And what are the contraindications? The contraindications are that either the patient is having major degree placenta previa, or she is having previous scarred uterus which was classical. The classical is actually the midline incision, or she is having any obstetrical emergency due to which we cannot choose the vaginal birth in this case. And also if the patient is having any comorbidity which is associated with some high risk factor. So in all these cases, definitely we have to exclude these before proceeding towards the vaginal birth after cesarean. So once the contraindications are ruled out, then we counsel the patient that yes, we can go for the VBAC, provided that there will be a continuous monitoring of the labor during the delivery. Now, why is there a need of continuous monitoring during delivery? The need of continuous monitoring is because the risk of rupture of the scar is there. Now, the question arises, it is very much important regarding MCQ point of view and also Viva point of view, that what is the risk of rupture? So, it's 0.5% rupture, risk of rupture in case if the patient opts for or she is spontaneous general delivery, and this risk increases to about 0.7 to 1% if augmentation has been given, and this now increases to about 2 to 3% if augmentation, and with induction it's about 0.7 to 1%. So we have to counsel about all these likely possibilities with the patient, and we have to counsel her regarding the success rate of vaginal birth after cesarean, and ultimately the patient herself is to choose that either she wants vaginal birth after cesarean or she wants elective repeat lower segment C-section. Now, if she chooses elective repeat lower segment C-section, then with previous one C-section, the guidelines say that it should be at 39 weeks gestation. So it is very much important MCQ as well, that if a patient who is having previously lower segment C-section, then at what gestation should there be the elective repeat lower segment C-section? It should be at 39 weeks gestation. And also, as far as MCQ or for Viva question it is concerned, both I've discussed the important points that with a patient who is previously having vaginal, previously having the lower segment C-section, then the risk of rupture in case of spontaneous vaginal delivery is 0.5%. In case of induction, it's 0.7 to 1%. And if augmentation is chosen, then it's up to 2 to 3%. So it's increased. And also we have to see other existing factors as well. And as I've told that we have to go for the continuous labor monitoring if the patient opts for vaginal birth after cesarean. Why? Because I've told that there is risk of scar dehiscence or scar rupture. And what are the signs which are taken up during the if there is scar rupture? This will be that definitely the patient will be having a weak or thready pulse. There will be abnormal CTG. There will be a loss of variability of CTG, and also there will be extreme abdominal pain or tenderness loss, and there will be change in the abdominal contour, and there will be ascent of the presenting part or station. The presenting part should not be palpable in this way, and also the fetal heart might not be auscultated. Why? Because there can be intrauterine death because of rupture. And also, what other risk factor that patient can, depending upon the degree of rupture of the scar, there can be vaginal bleeding, there can be hematuria, and ultimately, because of this bleeding, then ultimately the patient might be having signs of shock. And what are the signs of shock? Hemodynamic shock, circulatory shock. In this case, the patient will be having weak thready pulse and cold clammy skin, and she will be having oliguria and also palpitations, and also she might be having um altered state of sensorium or altered consciousness. So these are the signs which the patient might present if there is any rupture or dehiscence of the scar. So we have to be very much vigilant, and we should know the risk of if we have to know that is there any risk to of rupture. So we have to see the scar tenderness in the patient, we have to monitor the vital signs of the patient, and we have to deliver the patient generally very, very vigilantly. And furthermore, the question is asked even that if a patient who is having previous two lower segment C sections, then what is the preferable time for her elective repeat lower segment C section? Then the answer is that after previous two lower segment C sections, the elective lower segment C section is done at 38 weeks gestation. And in this regard, we do not opt for vaginal birth after cesarean because the risk of rupture is as much as 2 to 3%. Now, this has been increased in spontaneous with previous two. So, we do not go for the vaginal birth if patient is having previous two scars. And also, according to the guidelines, some studies were conducted that how do we monitor that this patient is either a case, a preferable case for vaginal birth after cesarean, or should she be chosen for elective repeat lower segment C-section. Then, by ultrasonography, they assess the myometrial thickness, at the level of uterine scar. So, if the myometrial thickness at the level of uterine scar was between zero point 0.4 to 2 millimeters, then they said it was having a high risk of scar dehiscence or rupture. But if the scar thickness at the level of uterine scar, or if the thickness of myometrium at the level of uterine scar was between 2.1 to 4 millimeters, then it's relatively thicker. So they said that it got relatively less risk of rupture or dehiscence. So it was actually an assessment, a random assessment of uterine scar thickness, and it has got no definite impact on the on our choice to decide that either we go for vaginal birth after cesarean or we choose the elective repeat lower segment C-section. But it's just a sign which an obstetrician can see to be on safe side. So, in short, the vaginal birth after cesarean is basically a very important topic in which you have to see that at which time we have to decide for VBAC, and what is the success rate of VBAC, and what is the risk of rupture, and what are the contraindications. And also, we should know that what are the things to be taken care during labor if we choose for VBAC, and also what are the signs of scar dehiscence. So these all are very much important regarding the MCQ point of view as well as the Viva point of view. So is the topic clear to you, or you want any question? You can unmute the mic, and you can ask if you want to ask any question, or if it's clear, then you can inform me. Okay, I'm going to end the session here, and I will share the recording on the group. Thank you.